buy-in, and some of the more seasoned medical providers showed some lower buy-in. And the buy-in actually wavered over time. So people were super excited at first, and then over time that kind of wavered a bit. And then we also noticed that the size of our clinics really influenced buy-in as well. So at the smaller clinics where we have more tight-knit and cohesive teams, it was a lot easier to roll this out and to encourage providers to use it. And I think I'm going to hand it over to my colleague Beth now.
Yep. Hi, everyone. Beth Feeble-Corn-Kennedy. So the second big lesson our team learned in our rollout is that the care package we created is incredibly robust and comprehensive. And in some ways, we received feedback from our PCPs that there was too much information for them and too detailed information at times in order to feel that they could use the components within the care package easily within their visit. So at times they gave us the feedback that they felt that it wasn't quite accessible. In our system in particular, they described that many of their visits have multiple complaints that are being addressed within one visit, and therefore needed to have a care package or have tools that they could easily weave in throughout a visit, for example, that might also be to address hypertension and diabetes. We had a little bit of an assumption that there would be times when they would have visits that were exclusively to address their patient's depression, and we learned that in fact that wasn't happening as often as we expected. And so going forward, one thing that we are looking at is how to create sort of a la carte components of our care package that might allow them to, again, weave these into a visit that might have multiple complaints that are being addressed. And then, as Dr. White alluded to, we are also going to continue to explore ways to strengthen the partnership that we have both with our PCPs that are in the clinics and on the ground, but as well as with our primary care leadership, and also hoping to look at how the care package, for example, might help our clinics to meet the Minnesota Community Measures standards that are being asked of us in terms of screening for and treating depression to remission. And so again, partnering with our primary care leadership, so those that oversee all of our primary care clinics, is one area that we are looking at. And then I referenced in the last slide that we're looking to adapt the care package so that it can be used a little bit more nimbly and again, woven into a visit that has multiple complaints. So in summary, our depression care package, as we've described, is a robust tool that's embedded into our electronic health record, which for us is Epic, and it's designed for primary care providers to enhance and support their treatment of depression in primary care, following the evidence that we have for primary care in treating depression.
Thank you so much. Are there questions for our presenters about the didactic that you heard today? You'll have to take yourself off mute and let me know if you have a question.
Jeyn, this is Jeff from Sanford Health. It's not so much a question as a comment. I'm having a little deja vu experience here because this seems so very familiar to what we did at Sanford a couple years ago. We called it the Primary Care Depression Toolkit, and had very much the same elements in it that our colleagues here are presenting. And I'm smiling because our pattern was very much the same, a lot of excitement, a lot of press to do it. And we rolled it out and everybody thought it was gonna be the sexiest thing ever. And some people really embraced it and others didn't. And I think our lesson over the last few years has been, it's a marathon and not a sprint. I know that's an overused cliche, but it has slowly but surely begun to change the culture. But I think our expectation was everyone would think it was as cool as we thought it was. And some people did and some didn't, but over time it begins to become part of the culture. And So my comment is patience, patience, patience. And thanks for that presentation.
Awesome. Thank you so much, Jeff. Anyone else with questions, comments? And as we continue, if you have a comment or things, we can go ahead and address that at the end. So thank you so much. What we're going to do now is go ahead and move into our case presentation. It's Ortonville Area Health Services today, and Twyla is going to go ahead and speak with us. Twyla, would you go ahead?
Sure, you can go ahead and advance. Ortonville, just to give you a little background, is a rural primary health care facility. We have 7 physicians, 4 mid-levels, a psychiatric mental health nurse practitioner, social worker, and a therapist once a week. We also have care coordinators or health coaches within our clinic, and we have 2 waivered Suboxone providers. We kind of wanted to talk a little bit today about population-based care, looking at triaging patients to behavioral health resources, kind of focusing with our chronic pain population that might have some depression and anxiety within it as well. Some of the patients in our population may or may not have pain management providers outside of our clinic. And then we also have a Living Well with Chronic Pain class that we offer to our patients free of charge. That is a several-week program, 6-week program that kind of walks them through different coping skills and things to live with the chronic pain. So our interest today, or things that we're looking at doing here in Ortonville, is we're wanting to increase our coping skills for individuals that are dealing with anxiety and chronic pain, and looking to how we can reduce the number of patients who are on chronic pain medications with benzodiazepines. So what we're hoping to get or work towards is we want to be able to engage our clinic's population to be aware of the benefits of integrated mental health, that not only does your physical health play a part, but your mental health also is part of your whole well-being, and trying to figure out how we can help the individuals with both areas. We've also been working towards breaking the stigma of obtaining services in a rural area. And one of the ways that we've done that is by embedding mental health services within our primary care clinic. That way, if individuals are coming to the clinic, they're not parking in front of a mental health building. That way, and they can obtain services with little to no stigma, just like they're coming in for an earache, sore throat, those kind of things. Other areas that we're hoping to work through is recognizing within our own staff members if we have any filters or assumptions that we have related to chronic pain or to any mental health concerns that may be inaccurate and may impact the care that our patients receive. And our hope is that Ortonville Area Health Services will be a safe place for individuals to seek care for chronic pain and for mental health services. So as we start looking at the cross model, we've kind of focused today our talk on the population-based care. And one way that we're doing this is we're screening through our EMR, which is Epic, to engage patients in behavioral health services. Kind of our SBAR for our case, the situation that we have within our population is we have some negative thought patterns that occur with some of our patients. We have challenges in finding ways to engage what motivates our patients. We have staff that have been trained in motivational interviewing, and we try to use that, but sometimes that can be challenging as well. And then also trying to collaborate our behavioral health providers with our primary care providers, trying to figure out what came first. Is the anxiety causing the pain, or because that individual is suffering from chronic pain, they may be having anxiety? So some of the barriers that we have come across while we've been working with this, is some of the patients are feeling judged for being on both chronic pain medicines or benzodiazepines. We have many patients who decline to see a mental health provider within our clinic, or they feel that there's nothing related as far as mental health goes to their chronic pain, so they're declining those services. We also have several individuals that have the history with both the anxiety and the chronic pain. A lot of our patients in this population also have history of strain or conflict with their family members. So sometimes they may not be wanting others to engage with their care. Financial concerns are big in our community. We have a lot of individuals that have fixed incomes or are lower towards the poverty line, where they may not have the financial resources. They don't have gas money to be able to go see a chronic pain specialist, or to travel other places to obtain additional support or services. We have several who seem like their anxiety doesn't resolve well with medication adjustments. Again, the challenges of figuring out what motivates the individuals. As I mentioned, the limited resources for transportation, and those who may decline mental health services or counseling. So what we've been doing here at OAHS is we've been working on targeting populations through our EMR registry through Epic. We've been working as well with our chronic pain management group on how can we focus on individuals who have anxiety and chronic pain, with the hopes of reducing the number of people who are on the benzodiazepines and chronic medications, realizing that some people need those medications as well for their situations. So it's not a blanketed type thing, it's kind of more case by case, figuring things out. We've tried talking with patients in clinic visits about the option of having behavioral health as well. We've tried cold calls with limited responses as well. So being in a small rural area, we're kind of wanting to hear from others on what have you done to kind of break the stigma of receiving mental health services even within primary care. Any pearls or words of wisdom on how you're engaging patients to accept some of the coping skills. Again, we continue to use motivational interviewing with our patients, with our staff members as well, but just kind of wanting to hear from other people how you've been implementing this. And sounds like Hennepin County has tried this too, as well as Sanford. Just wanting to hear from some of you who are further along on the journey, any words of wisdom or pearls that you'd be willing to share with us.
Okay, awesome. Thank you so much. Let me just kind of remind you about the ECHO process. So now that we've heard our didactic education piece from Hennepin Healthcare, and we've heard our case presentation from Twyla from Ortonville, now what we're going to do is go ahead and ask for some clarifying questions about the presentation that you heard from Twyla. Are there clarifications that you would like to ask for so that you can gain more information? Because we will go into recommendations after. And after our clarifying questions, what I'd like to ask you is that all of our learner groups and our other folks who are on, go ahead and I'm gonna ask you to ask your clarifying questions first. I'm gonna stop sharing the presentation so that I can then see you all. So there we go. All right, so now I can see you. So we have quite a few folks that are not on camera. I'm gonna ask you folks to go ahead and ask your clarifying questions first and unmute yourself and just go ahead and start talking, and then we will jockey through that if two people come on at the same time. So clarifying questions. Okay, I'm going to open it up to anybody else that's on video as well. Clarifying questions for Twyla.
Twyla, this is Jeff Leichter from Sanford. Thanks for a really great presentation that's, I think, very familiar probably to everybody on this meeting. I wanted to just ask you to clarify, in one of the earlier slides, you mentioned something about you're working on addressing the filters that your staff has, which I inferred meant some kind of inherent bias or predetermined judgmental attitude or something like that. I think that's a great idea, but can you just say a little bit more about how you're doing that?
So basically with trying to, is it echoing?
You're okay out here, Sally.
Is it sound okay?
Yes.
Basically trying to decrease the stigma around chronic pain and benzodiazepines and everything that goes with that. We've been working with the staff so that they better understand the reasoning why we might want to decrease different medications that are with each other. We've been working with them on how to approach patients when they're at certain levels of pain with wanting certain medications and refills. We've worked a lot with the nurses just to be able to have the conversation comfortably and let them know that they can be a part of the discussion, not just passing it right on to the provider. And I think a lot of that has started to help them understand any preconceived notions that this patient asking for a med is probably because they're taking it incorrectly because this, that, the other thing, or if they're calling in upset, it's probably because they're seeking, and they're starting to realize that there is a bigger picture with the mental health and the opioids and the benzodiazepines, all of that. And so we've been working really hard to get them to approach it differently.
Thank you. Other clarifying questions out there? Either wave at me or go ahead and start speaking. You guys are all interested in getting to recommendations and to the meat today, aren't you? I understand. I see lots of smiles and giggles now. Okay. All right. Well, then let's go ahead and move into recommendations. And if I can have anyone who's interested, go ahead and put your comments out there this morning. Anyone want to unmute yourself and make a recommendation or share an idea, maybe some innovative thing that you've tried?
I'm sharing something with the group here. This is Kristy White. The other day, I actually had a primary care provider ask me for something that she could give to a patient to educate the patient about how a psychologist can help with pain management. And so I shared a link with everyone there. It's a PDF that can be printed out and handed to patients for just some basic education about what psychologists can do to help with pain management so that they can start thinking about other options in addition to pharmacotherapy.
Awesome. Thank you so much, Kristy. And we will make sure that you all get that in follow-up as well. Okay. Other recommendation thoughts for our folks at Ortonville?
This is Mirza from Alina Health. I like the approach about training staff in motivational interviewing, and so you're taking a comprehensive approach on addressing this problem. I think it's important to also recognize it is a very difficult problem, but I think the culture is very important. So all staff and all providers giving a consistent experience to patients, and that everyone in the organization is invested in reducing benzodiazepines and having this sort of treatment plan, if you will. So I think just having everyone invested in it across the board would help, and sort of that might help other patients understand that, even those that might be resistant to this approach.
Thank you. Joellen, go ahead.
Thank you so much for the presentation, Twyla. I really appreciated it, and I nodded the whole way through because I know exactly how you're feeling. I'm one of the people at Hennepin that actually works in a more traditional health area, and so I work in our pain clinic that is separate from primary care, but I have experience in both. One of the things that we did when we set up our pain clinic was everybody has to see me as part of their integrated care in our clinic. And so we have a very team-based model. Our patients see the psychologist, the medical provider, the nursing staff, and our pharmacist that's embedded as well. And it's just an expectation. And so that, I think, helps to take a little bit of the stigma out of it. The other thing that we're going to be launching soon is group medical visits, which I also hope will help dramatically increase the patient's buy-in, that there's a lot more that they can do that is other than medication-based intervention.
Thank you.
This is Jeff from Sanford. I really would echo what Joellen just said. What I heard, Twyla, in the presentation is that somewhere along the way, patients are offered a referral to a behavioral health provider. And I can't help but think that at that point, if you were to sort of pause that for a moment and then consider what might be going through that patient's mind at that time, particularly in a rural community, no matter how genuine and absolute you're trying to be in your offer, I wonder if their filter isn't, this person thinks I'm exaggerating, they think I'm crazy, they think I'm abusing, they don't believe me. And of course, that's not your message, but that may be their perception. So to Joellen's point, I wonder if there is a way for you and your team, rather than to say, hey, we have this other service, which almost inadvertently promotes a silo, that you can get real care here, or there's these other people that go over to these people. But rather, in the spirit of integration, as Joellen is saying, and as Mirza, I think, also implied, is that can this all be one continuous service without any distinction about you're going to see a real doctor and a head doctor, but rather we have a team, and the team is comprised of experts, all in fields where we know make a huge difference in your ability to manage your care. So I would just sort of echo what my colleagues are saying here, is that maybe that is a place to move towards, is to stop creating distinctions about different professionals and really to try to sell it as a care team, all of whom have their individual contributions to make.
Thank you. More thoughts or recommendations for Ortonville folks? I mean, because the whole stigma piece and the culture that's needed, for sure. And that is, you know, very, very hard to break the stigma. And I mean, that one continuous service and the team piece of, you know, I work with, you know, Sally, Sarah, and Twyla versus I'll have you see this other team. Absolutely. So thank you for that sharing. Other thoughts that have popped up for anyone that you'd like to share with the group?
This is Gretchen. I sent Jeyn this article a couple days ago, but we might be able to send it out to everyone. There's a really good article that I found that talks about how to deal with difficult patients in pain clinics, and I think we all have experienced those patients who, no matter what you do, you just can't seem to get a handle on things. And so this article is really good. It just kind of goes through and helps provide some background about what might be going on with those patients. And I do think that there's kind of this two-sided thing. You know, there's definitely what Mirza and Joellen and Jeff talked about with the integration piece and just kind of making, you know, reducing the stigma. And then there is also probably a education component for the people in the clinic about, you know, there might just be this background too with some patients that are going on. Sorry about the background noise. And so anyway, this article kind of goes into what might be going on with these patients, and then also some ways to strategize about how to handle them in ways that you know, create empathy and create compassion.
Thank you. So we absolutely will get the link from Kristy and the article that Gretchen has located out to you folks in our follow-up as well. Other closing recommendation thoughts that we want to grasp, or are there any thoughts or comments regarding the presentation of the depression care package from our folks at Hennepin Healthcare? Lots of food for thought today, absolutely. Okay, Gretchen, can you go ahead and give us a recap of the recommendations that surfaced?
Yeah, so we've got a clarifying question we had was talking about how you address the filters that the staff have around chronic pain and anxiety. Then our recommendations included let's see, Kristy suggested a link that she has that psychologists can do to help with pain management, a handout that can be given to patients. And then we have a discussion around just really including everyone in the organization as part of the culture of the treatment plan of reducing benzodiazepine use. And then Joellen talked about the just including everyone as a team, and Jeff kind of reiterated that as well and used the language of making it a team of experts, that everyone gets the same care instead of some people get real care over here and other people get different care over here, really that integration language. And then we'll be sending an article out for background on patients like this.
Awesome, thank you. Any other recommendation tidbits that we need to grab from the audience? Anything that's missing?
One quick comment, and it may be not at all helpful. We've been working on a task force at Sanford around suicide, so it's a very different topic. But one of the things that we kind of had an epiphany about was that we needed to add a consumer to our task force, somebody who had personally experienced suicide, as we were creating a bunch of enterprise initiatives. And we have found that to be enlightening, to say the least, because we have a lot of professionals who are quite learned, but maybe haven't personally experienced suicide. So maybe something just to toss around is there any value in having a consumer consult with your team who may be somebody that has had some recovery from a chronic pain issue or is dealing with a chronic pain issue that might be able to give you a patient perspective that maybe we just have a blind spot about in terms of how we're addressing that. So if you'd asked me 10 years ago, I would have said that's nonsense. But as I've gotten older and grayer, I realize that everybody has a contribution to make. So that's just something to consider as well.
Thank you. Thank you.
And
Okay.
thanks for all the feedback. We greatly appreciate it.
Thank you. Excellent. Okay. Well, thank you all so very much. As we are closing today, remember you'll get an evaluation by SurveyMonkey that will come out to you after. Please provide feedback because it's very beneficial as we continue to do our PDSAs on this process and continue to move forward. So please fill out your evaluations and get those back via SurveyMonkey. And we have our next event will be on April 7th, and we will have Allina Health doing our didactic sharing, and we will also have Community Health Services Inc. doing our case presentation. And that is our last session for our ECHO for our 6-month ECHO as well. So just letting you know, we will also send out a summary of what happened today, and these 2 reference resources we'll send out. So thank you all very much. If you have any other comments or questions, please reach out to me. Very much enjoy this process and enjoy seeing and talking with all of you. So have a fabulous day, and we'll talk again soon. Bye-bye.
Bye. Thank you, Jeyn.
Thank you. Thank you so much.
Hey, Jen, can
Yeah.
Sarah and I talk to you for a minute?
Sure. Hang on just a minute.
Either way, I don't care. We were just wanting to touch base when you want to follow up with us, and we figured as long as we were all here.
Okay, hang on a minute. I just want to stop the recording. Patty, how do you stop the recording? I just don't want to make sure I don't lose it. Sounds like it's not letting me do it. And I don't know if you have to do it from your computer. We're recording this event, so Patty's going to go and turn it off from her computer.
Okay.
And then we can chat. I thought it went well, you guys. It was awesome.
Thank you.